Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Hirsutism, increased or excessive growth of terminal hair in a female in an androgen dependent fashion. That means male pattern distribution on areas like face, chest, lower abdomen, arms, thighs, and buttocks. These are all androgen dependent areas. In these areas, if terminal hair is growing in excess in a female, it is called hirsutism. Remember like this, hirsutism. Her means occurs in females. In males, it's normal to see a terminal hair in these areas, but in a female, it's called hirsutism. Coming to pathogenesis. Why hirsutism occurs in androgen dependent areas? Because of sensitivity of hair follicles to plasma androgens is a site specific manner, means on scalp terminal hair in response to plasma androgens will metamorphoses to vellus hair, but same androgen on acting on androgen dependent sites which are usually having vellus hair. In females in androgen dependent areas, they will usually have vellus hair, which in response to plasma androgens converts or metamorphoses to terminal hair, thick black hair, which are more lengthier than vellus hair. It will be not cosmetically good. In females, from where androgens are produced? From adrenals before puberty and from puberty ovaries. During pre-puberty, androstenedione, precursor of testosterone, DIA, precursor of androstenedione, dihydroepiandrosterone, DIA S for sulfate, are secreted. These are all will lead to pubarchy, means appearance or development of hair in pubis and axilla. Before puberty, only organ adrenal to secrete androgens in female. After puberty, under the influence of LH, ovaries secrete androstenedione. During puberty and reproductive age, LH acts on theca cells of the follicle of ovary and stimulates it to produce androstenedione. After menopause, ovaries stop producing ova, but it will continue to produce testosterone from theca cells. During puberty, androstenedione. Here from adrenals also I wrote androstenedione. From ovaries also same I wrote androstenedione. Nowhere I wrote testosterone. From where this androgen testosterone comes in a female. Majority of testosterone is derived from peripheral conversion by enzyme 17 beta HSD, 17 beta hydroxysteroid dehydrogenase. Peripheral conversion means in skin, liver, prostate, everywhere. This enzyme catalyzes the reaction, conversion of androstenedione to testosterone and testosterone to androstenedione depending on the organ. What is the normal range in a normal female? 15 to 70 nanogram per deciliter of testosterone, out of which 80% is bound to sex hormone binding globulin, 19% to albumin, only 1% is free to exert its action in a normal female. What happens in a female with hirsutism? This free testosterone will get elevated. Why? Because of reduction in sex hormone binding globulin or increase in production itself. If sex hormone binding globulin gets reduced, testosterone will no longer be bound, it will become free, then it will cause hirsutism. Or if sensitivity of hair follicle increases to normal testosterone levels are normal only, but Hair follicles, sensitivity to testosterone elevated, then it will produce hirsutism. Or both the testosterone is normal, sensitivity of the hair follicles are normal, but increase in metabolism of testosterone at end organ level to dihydrotestosterone. What is dihydrotestosterone? Most potent androgen than testosterone, formed from testosterone in hair follicle by enzyme 5 alpha reductase, specifically type 1 5 alpha reductase type 1 to dihydrotestosterone. Both testosterone and dihydrotestosterone are capable of converting vellus hair, the usual hair in androgen dependent areas in a female, to terminal hair, thick black lengthier hair. Coming to clinical findings, apart from hirsutism, other cutaneous signs of increased elevated androgen levels, that is nothing but hyperandrogenism. If androgens are elevated very high levels, excess amounts, then it may land up into virilization. What are the features? Acne, androgenetic alopecia, acanthosis nigricans, A, seborrheic dermatitis, irregular menses. These are all features of hyperandrogenism. Features of virilization. Virilization is nothing but menization of a female. Clitoromegaly, greater than or equal to 1 centimeter enlargement of clitoris. Deepening of voice like men. Male pattern baldness like men. Increased libido, decrease in breast size, increase in muscle mass like men. Complete absence of menstruation, amenorrhea. Menization of a female, virilization. All virilized females will have hyperandrogenism, but all females with hyperandrogenism does not land up in virilization. If values of elevated androgens are not that much high, it will stay there at the hyperandrogenism level with acne, androgenic alopecia and all. It may not land up to virilization. Coming to modified Ferriman Gallwey score, WAY, not that way, WEY, Gallwey score, used to assess the degree of hirsutism in a total of 9 areas. It is called modified Ferriman Gallwey score. The original Ferriman Gallwey will assess 11 areas, here 9 areas. Upper lip, chin, on face. It's not considering size of the face, the beard area, which is also an androgen dependent area. Chest, upper arms, upper and lower back, thighs, abdomen and pelvis. These are all 9 areas where we will give each area a score of 0 to 4 corresponding to hair density. If greater the hair density, higher the score. Highest score is 4, lowest score is 0. 0 means no hair. Wherever I tell the word hair, it's nothing but terminal hair. This is the culprit causing hirsutism. 1. Minimal amount of terminal hair is seen. 2. More than minimal amount of terminal hair is seen but less than a usual man will have. 3. Like a man but less than a very hairy man. 4 means extensive terminal hair like a very hairy man. 3 is usually like a man. 4 is usually like a very hairy man. 2 is less than a man but more than minimal, that is 1. When combined, total score allows overall diagnosis. Less than 8 means normal, no hirsutism. 8 to 4, mild hirsutism. More than 15, moderate hirsutism. If it is more than 25, severe hirsutism. What are the drawbacks? It is subjective, time consuming, affects the privacy of the patient. It fails to account other androgen dependent sites. I already told you, it ignores beard area, sides of the face. There is no scope for focal hirsutism and does not consider the use of cosmetic modalities. When a patient hides any procedure like cosmetic modalities, shaving or anything, and then comes to us, it is not considered. We will calculate the score. Coming to evaluation and causes of hirsutism. First we have to listen patient's story, his history and physical examination. In physical examination, if we find excess hair growth in face and androgen dependent sites, then we will consider hirsutism. If same hair growth is generalized not only on androgen dependent sites, other sites, not only terminal hair, other type of hair, vellus hair is also excessively grown, then we will consider hypertrichosis. Now we are considering hirsutism. Now we have to evaluate what are the causes of hirsutism. We will ask for menstrual cycle. If it is regular, means hypothalamo pituitary ovarian axis is perfectly all right. So we will see next levels of testosterone, features of hyperandrogenism. If it is there and testosterone is elevated, then we will say it as idiopathic hyperandrogenism. If testosterone levels is also normal, there is no features of hyperandrogenism clinically, then we will consider idiopathic hirsutism with normal levels of testosterone. Now menstruation is regular, hyperandrogenism features are not there, nothing is there, just hirsutism is there, no other cause is found, then we will call it as idiopathic hirsutism. Same, but some elevation is there in testosterone, but we don't know why. Some hyperandrogenic features are there, we don't know why, then idiopathic hyperandrogenism. Now coming to irregular menstrual cycle. So some problem is there in endocrine organs or some other problem is there which is causing abnormality in menstrual cycle. Now we will see any sudden onset of virilization is there, sudden onset hirsutism along with virilization is there or not. If there is sudden onset and virilization also, then we have to consider malignancy and do imaging studies to find out any mass. As I already told you, very high amount of testosterone greater than 200 nanogram per deciliter virilization will occur. We have to consider malignancy, ovarian malignancies like Brenner's, Hilus, gonadoblastoma. We have to do imaging studies to find out any mass, USG, CT, MRI to find out ovarian mass, pituitary mass, adrenal mass or some other masses like arsinoid tumor, small cell lung cancer, choriocarcinomas. If virilization is there, we have to consider malignancy. If there is slow onset of hirsutism without any virilization, we have to exclude secondary causes with hyperandrogenism. Androgens are elevated but not that much of causing virilization, 100 to 200 in between this range. Then we have to consider PCOS. In USG, it will have polycystic ovaries. Main cause of PCOS is elevation in LH, reduction in FSH. LH, if elevated, it will stimulate theca cells to produce androgens. Here LH is to FSH ratio will be greater than 3. Then FSH will be reduced. If FSH is reduced, it will not stimulate granulosa cells to produce estrogen. So ultimately estrogen will be reduced. Estrogen and sex hormone binding globulin goes in a same way. If estrogen is reduced, sex hormone binding globulin will also be reduced, leading to elevation in free testosterone causing hirsutism. Next, positive glucose tolerance test. There will be insulin resistance leading to elevated insulin levels. Here, insulin and sex hormone binding globulin are inversely related. If insulin is elevated, sex hormone binding globulin will reduce, leading to elevation in free testosterone and again hirsutism. Next cause, non-classical congenital adrenal hyperplasia, late onset congenital adrenal hyperplasia. It will occur after 10 years of age. Main cause is 21 hydroxylase deficiency. If 21 hydroxylase is deficient, 17 hydroxyprogesterone will get accumulated and elevated because it won't continue to form cortisol. Cortisol levels will reduce or it will be in a normal. So all the elevated 17-hydroxyprogesterone will be diverted to form androgens. Ultimately, hyperandrogenism, hirsutism. Hallmark feature is 17-hydroxyprogesterone elevated more than 800 nanogram per deciliter. If cortisol levels are reduced, there will be no negative inhibition. There will be release of ACTH to produce cortisol in response to low cortisol. Saha syndrome means seborrhea, acne, androgenetic alopecia, and H for hirsutism. There are 4 types of Saha: ovarian, adrenal, hyperprolactinemic, and familial Saha. Next, Hayran syndrome. HA hyperandrogenism, IR insulin resistance, AN acanthosis nigricans. It is a subset of PCOS and a severe form of PCOS. In all these causes, we will see hyperandrogenism. Next, without hyperandrogenism, all endocrinopathies like hyperprolactinemia, where serum prolactin levels will be elevated obviously, and it will lead to reduction in sex hormone binding globulin, so free testosterone is more. Hirsutism. How? Here prolactin inhibits gonadotropin, LH and FSH release. Ultimately, FSH is reduced. It will not act on granulosa cells to produce estrogen. Estrogen is reduced. Ultimately, sex hormone binding globulin is also reduced. Next, hypothyroidism. In response to low thyroid hormones, thyrotropin releasing hormone will increase and stimulate both thyroid stimulating hormone and prolactin. So again here also prolactin level increases, leading to estrogen level decrease and reduction in sex hormone binding globulin. Next, acromegaly. Here obviously growth hormone will be elevated, which leads to increase in insulin-like growth factor. Both growth hormone and insulin-like growth factor will directly stimulate 5-alpha reductase to produce dihydrotestosterone from testosterone, which is most potent and leading to hirsutism. Again here insulin-like growth factor, insulin is elevated. Insulin has inverse effect on sex hormone binding globulin. So sex hormone binding globulin will be reduced. In all endocrinopathies, sex hormone binding globulins are reduced directly or indirectly. Coming to Cushing syndrome, there will be elevated 24-hour urinary cortisol levels. Here along with cortisol, androgens also will be elevated. Here insulin resistance will be there, insulin will be elevated, leading to reduction in sex hormone binding globulin, ultimately leading to hirsutism. It is of 2 types, ACTH dependent and independent. If ACTH is elevated, ultimately adrenal glands will be stimulated to produce androgens. Same mechanism here also in small cell lung cancer, ACTH will be elevated. Carcinoid tumor also ACTH will be elevated, leading to hirsutism. Coming to pregnancy, because of beta HCG, which is structurally and functionally similar to LH. What LH will do to theca cells? It will stimulate to produce androgens, leading to hirsutism. Same mechanism here also, elevated beta HCG. In choriocarcinoma also there will be elevation in beta HCG, much more that in pregnancy. So in pregnancy it will stop until hirsutism. Here it will lead to virilization. Next, drugs, iatrogenic. If all these causes are ruled out, we will go into consideration of idiopathic hirsutism. What are the drugs that causes hirsutism? Cause of hirsutism is nothing but androgen. If we give the same androgen, which is synthetic testosterone from outside, anabolic steroids, it will lead to hirsutism. Next, glucocorticoids, cyclosporin, mycophenolate, mofetil, valproate, phenytoin, soralens, penicillamine, danazol, diazoxide. All these drugs will lead to hirsutism. PCOS is the main cause, most common cause of hirsutism in pubertal and reproductive ages. How we will diagnose PCOS? 2 out of 3 in Rotterdam criteria, oligo or amenorrhea or anovulation, hyperandrogenemia and or hyperandrogenism. Means clinically we will see features of hyperandrogenism. Hyperandrogenemia means in blood elevated testosterone is called hyperandrogenemia. On USG polycystic ovaries, either more than 12 or equal to 12 with 2 to 9 mm of size, or and more than 10 cc volume of ovaries in each ovary or any one ovary. If it is there, all these follicles more than 12, 2 to 9 mm will be in the periphery of the ovary in a string of pearl appearance. Management. Main lifestyle modification, the female is having PCOS or obese. Next, coming to pharmacological intervention. OCPs 1 pill per day, first line of therapy in females not seeking to conceive. Mechanism of action, it reduces ovarian androgen synthesis and increases sex hormone binding globulin. Adverse effects, breast tenderness, headache, migraine, melasma due to hormonal change, increasing risk of venous thromboembolism. Estrogen will lead to thrombus formation and thickening of the blood. Contraindications, breast cancer, uncontrolled hypertension more than 35 years of age. Absolute contraindication is active smoker. OCPs are absolutely contraindicated. Why? Smoking is a risk factor for thrombus formation, and here OCPs also will form venous thromboembolism. Any thromboembolic or cardiovascular diseases, OCPs are contraindicated. It is a category X drug, absolutely contraindicated in pregnancy. Next, glucocorticoids. Where a female is seeking pregnancy or OCPs are not tolerated or have suboptimal levels to OCPs, or with non-classical congenital adrenal hyperplasia. I already told you in drugs causing hirsutism, second drug glucocorticoids. Again here we are giving as a treatment. There, if glucocorticoids are given in high doses for a long period of time, it may lead to hirsutism. Here we are giving very low doses, prednisone 5 to 7.5 mg at night, dexa just 0.5 mg at night. Mainly in adrenal cause. If adrenal glands are overactive, we will give low dose of steroids to reduce adrenal androgen synthesis. Adverse effects, hypertension, we already know, glucose intolerance, Cushingoid changes, psychosis, peptic ulcer disease. It is a category C drug, avoided in uncontrolled hypertension and diabetics, as it may lead to glucose intolerance and hypertension. Mainly glucocorticoids are for adrenal cause. Coming to anti-androgens, if OCPs are not working or along with OCPs to increase efficacy, we will add an anti-androgen. First line of anti-androgen, spironolactone. It is a potassium sparing diuretic, 500 mg BD. Coming to mechanism of action, competitive inhibitor of androgen receptors and 5-alpha reductase, to some extent very less inhibition on 5-alpha reductase. It increases sex hormone binding globulin and reduces androgen synthesis. Side effects, polyuria, hypotension, headache, syncope because of hypotension. Hyperkalemia, it is a potassium sparing diuretic. All anti-androgens will lead to decrease in libido. Next, irregular menses. Category C drug, contraindicated in renal failure. It is avoided along with other potassium sparing diuretics. It may aggravate hyperkalemia affecting heart. Coming to second line anti-androgens, both finasteride and cyproterone acetate are category X drugs, absolutely contraindicated in pregnancy. These are 5-alpha reductase type 2 enzyme inhibitors. If 5-alpha reductase is inhibited, testosterone won't get converted to dihydrotestosterone. Finasteride dose 1 to 5 mg per day. Adverse effects, hepatotoxicity. All anti-androgens will cause decrease in libido. Coming to cyproterone acetate, 25 to 100 mg per day from day 1 to day 10 of menstrual cycle. What if these drugs are given in pregnant? What will happen? It is an anti-androgen, means it will reduce androgen levels. Without androgen, male fetus will not form male external genitalia, so there will be feminization of a male fetus. Next anti-androgen, flutamide, non-steroidal competitive inhibitor of androgen receptor, anti-androgenic action, 62.5 to 250 mg BD, category D drug. It is not recommended because of its hepatotoxicity. Next drug, bicalutamide, 25 mg OD. It will have less hepatotoxicity compared to flutamide. Ketoconazole, 400 to 600 mg OD, category C drug. What is the mechanism of action of ketoconazole? Mainly adrenal androgen synthesis is reduced. Adverse effects, headache, nausea and hair loss to ketoconazole. Insulin sensitizer. Why insulin and sex hormone binding globulin are inversely related? If insulin is high, automatically sex hormone binding globulin will reduce, leading to hirsutism. Metformin 800 mg BD or 500 mg TID. Adverse effects, B12 deficiency, GI upset, lactic acidosis. Insulin sensitizers, other insulin sensitizers can also be given. Gonadotropin releasing hormone analog like leuprolide acetate, 7.5 mg, only monthly once IM. What is the mechanism of action? It inhibits LH, FSH. No LH, no androgen, no FSH, no estrogen. If estrogen is not there, it will lead to osteoporosis. So as to prevent this, estrogen is added back as an OCP. Hot flushes, these are all adverse effects. No androgen because of no LH. Where it is given in severe hyperandrogenism, where OCPs also failed, anti-androgens also failed, then we will consider GnRH, leuprolide acetate. Coming to topical eflornithine hydrochloride, 13.9% cream, we will apply BD. In the name itself, it's there, ornithine decarboxylase inhibitor. What it will do, it slows down the anagen phase. Anagen phase is the active growing phase of a hair. So terminal hair anagen phase will be slowed down, so it won't grow. Terminal hair won't grow. US FDA approved this eflornithine hydrochloride for facial hirsutism. If it is very mild, limited to face, then we can give only eflornithine hydrochloride as monotherapy. If in moderate cases, as an adjunct to lasers or all our drugs. Like any other topical, acne, burning, irritation, ACD, adverse effects. Fluoridil, 2% gel. It is an anti-androgen. Topilutamide. It acts only on the skin. So there is no reduction in libido like all oral anti-androgens. Coming to mainstay of treatment, here remains removal of hair. Temporary removal, which is self-administered through waxing, bleaching, plucking, shaving or by using depilatory creams. Permanent hair removal done by experts. Electrolysis or laser hair reduction like photoepilation. If any tumors are there, surgical removal of the tumors. At the end, we will see differences between hirsutism and hypertrichosis. Hirsutism, I already told you, remember, like hirsutism, only in females. Here it is in all age groups, all genders, both males and females. Here only terminal hair. Here all types of hair, vellus, lanigo, terminal hair. Here only on androgen dependent areas. Here any area other than androgen dependent areas all over the body. Hirsutism responds well to treatment. It occurs during puberty or later. It occurs at any age group. Congenital hypertrichosis forms will not respond well to treatment. Remember the channel name, The Average Dermadoc. Don't forget to share and subscribe. Thank you. Hasta la vista. Das vidania.